Any questions to Dr. Rosa? I'm sure you do.
Well, first I would say that this is not causing MS. Neither is CCSVI. Because MS is a diagnosis by definition that there's no cause for the demyelination that's done. So every time we pull out a cause of demyelination that was originally called MS, we're now talking about something that's no longer MS. It doesn't change anybody's patient's problems, but I think we have to be careful. I think it may be associated with CCSVI, for sure. It's very interesting. And I have my head spinning here, because I think we have patients that are probably we could explore this together, in ways that evaluate. For example, you have ways of looking at CSF flow that we can't see. We're seeing a global vein that you're really not seeing, and I think working together we could really look at this better. It may be that some of those high stenoses can be fixed. I mean, I don't think all of them. And you're certainly not doing anything, at least not now, to fix the lower part. So there's a mutualism here that can be beneficial. I think that's the first thing. Nice to meet you. I have a question though. I assume, but I don't know. I would like to have it confirmed. Have there been studies of healthy controls in upright MRI to look at these things? In other words, you have a cohort of patients that are blinded as whether they have the lesions or not, and you just clearly can see distinct differences between a healthy control and somebody who's had MS, Parkinson's, dementia, any of those things.
We're just starting now. As I mentioned, our original study was a 43-case study, and out of the 43, we did take, I believe, 18 out of the 43, and we did a sham treatment, and then we put them back in the MRI, and we saw no change whatsoever in spinal fluid flow pattern or arteriovenous flow pattern. And then we took them, and then we crossed them over, and then we treated all the sham group, and they all had the same improvement that we saw in the original group. So we haven't done normal, cohorts yet. But we have sham people and found that the sham changed nothing, and the only intervening, explanation would be when we corrected the atlas misalignment that did bring about the change in the spinal fluid flow wall.
Yeah, but that's not the question. The question that our skeptical colleagues seem to always throw at us is, how do you know that healthy controls don't have this problem, with the tonsil bouncing around, unless somebody looks at those patients?
Again, we're just in our infancy stage. I did do a scan about 3 weeks ago of a patient who was asymptomatic and normal, and I have it here, and I can show you that none of the findings that we are finding with those trauma cohorts or any of the other cohorts we demonstrated today had anything remotely close to those findings. So I'm here to say that we have a lot more questions than answers. We have better questions to ask. My colleagues and I are working diligently at doing a lot more research. We have a lot ahead of us. Like Dr. Sclafani says, I believe that, or I don't necessarily believe that we're looking at a separate entity, that MS is a sole separate entity. I think that there are common threads that we're seeing, and I don't think that the demyelination is the only answer to what MS is. I think that there are other things involved. What those other things are involved is up to people like Dr. Sclafani, and our future work hopefully can bring light to. And I'm hoping that one day we might have better answers for that.
I want to go back to the venous problem. Your presentation, we know you use IVUS for your treatment planning, and then for certain criteria. With IVUS, obviously, you see actual problem right there. With venograph, just a little bit more vague. You may have to rely on the flow, etc. Sometimes you see the blockage, sometimes you don't if you're not doing it the right way. Jerry, how do you decide on who to treat and when? Because some of these patients, they do have 50% that you can detect, maybe more, etc. Even though some lower degree of stenosis may have more reflux during the venogram, the position of the patient may change things. It is not simple. I mean, do you have an algorithm or?
Well, obviously we do diagnostic venography on all of these patients, and we try to identify stenosis. And quite frankly, if we don't see a stenosis in one view, we look at additional views to ensure that we're evaluating. But I tend to be extremely aggressive when it comes to angioplasty. So even if I'm seeing a small diameter reduction, or certainly if I don't appreciate significant diameter reduction, but I'm seeing competitive outflow from collateral veins, we'll go in and we'll dilate the area. Many times you'll unmask an underlying stenosis that you didn't see and you didn't detect angiographically because of the fact that maybe a valve that has flow around it, so you're getting this masking of the lesion. So I was remarking to Dr. Englander, I would say 100% of my patients get angioplasty of the jugular veins, and about 95% of them get the jugular and the ascus vein done, because we tend to be very aggressive with angioplasty. Very conservative with stents, but very aggressive with angioplasty.
So you're essentially in a way using your balloon as a diagnostic tool too?
Well,
in a way.
Yes, at times. I would say most of the time we detect some degree of stenosis. So.
Dr. Englander, you guys are doing a trial, so that's hopefully going to shed a lot of light down the road. You have a lot of experience, so it's not going to be questionable like the existing trial. And then what is your approach when in the trial, when you're deciding to treat? Is there has to be certain criteria in the trial. We can't just,
in the trial, first, I mean, we don't use IVUS. We're basing it on immunographic findings. We use dilute contrast, like Sal alluded to, because when you have that in contrast, you can see the subtle abnormalities within the wall of the vessel. But so we need to see objectively a greater than 50% stenosis, or collateral flow, or greatly diminished outflow. So lots of times when you inject the contrast in a normal vessel, it'll just wash away. But if there's delay, or if it's just not washing away, then we're assuming that there's a stenosis that we can't see. And I guess in the trial is different than when we've been treating patients outside of the trial, because just like Jerry said, often things will be, we look at the venographic findings, they're marginal, but we also are, have a very low threshold and are aggressive with angioplasty because we don't know what's significant, and because we know that there are things that we can't see with venogram that have been seen on ultrasound. When we put a balloon up, very often there will be a waste which surprises us based on what the picture looks like. But obviously in our trial, the criteria for treatment are strict and very well defined.
So I'm curious, we had this discussion in Orlando about the variability and the difficulty to measure venous stenosis, because the vein can be extremely dilated. They're not as reproducible as the carotids are, by using massive criteria and so forth. So, how do you actually go about measuring? Do you, within 2 centimeters of the area that's suspected stenosis, the largest diameter of the vein? How do you define that? Just out of curiosity.
It's the ratio. You take the narrow. We're looking at the narrowest area compared to the area. I mean, if there, sometimes there'll be a big focal bulge right before,
Right, but so let's say that the vein is very, very large and tapers down to the stenosis over a 3 centimeter length. Do you go to the largest area, or do you have a limit about how high you'll go up before you know what I'm saying? Do you take the largest portion of the vein compared to the smallest, or are you limited that you have to do it within 2 centimeters?
I don't think that is clearly defined.
The operator is not. And there's no way out of that. I agree with that. And there's because everyone's anatomy is slightly different. As if you look at one versus the other, there may be a huge difference between the two people. And I agree with the flow being a problem. Is I think an issue. If you use IVUS, which makes things a little bit more difficult during the procedure, but that's a very useful tool. I think though. We need to come up with a common way of a tool that is accepted by everybody. That's kind of should be one of our goals.
I think that we have a real problem, because I don't know, and I've been trying to figure this out for a really long time, is what makes 50% stenosis some holy grail. I think we
Well, that
really...
isn't, I mean, we're also using.
No, I
other
understand,
criteria. Okay, so.
but I'm saying it may be that 20%. In other words, we don't know, and then I've been talking to, fluid dynamics physiologists who really have to give us an answer about how flow is, what's the effect of narrowing of a low pressure system. Everything's based on high pressure
Well, based on
arteries,
what we
right?
know about the arteries, right?
Yeah,
But that,
and
I mean,
they're very, very
in our practice, outside of the trial, just the same as we're very aggressive, and we don't know what is this significant number. And then patients are always like, what percentage narrowing did I have? And we always go, it's either mild or severe, but as far as people, they're really focused on wanting a number.
In the trial, you're probably better off having a higher degree of stenosis because you'll have a greater likelihood of showing a
Right,
benefit.
I mean, we need to have something objective on it.
Just to clarify,
Consistency.
yeah, aggressiveness that's being mentioned is not being really aggressive on the vein. It's the threshold to treat is very low.
Right, exactly.
Okay.
Yeah, thank you.
You take the gradients in the mean, that, so that may be important in mild or moderate, whatever it is, but
Well,
gradients there.
We had a workshop today with Dr. Sclafani, and we discussed that extensively. I have personally measured gradients in my first 25-30 patients, and in a few patients who had severe obstructions, like total occlusion on one side, several levels of high-grade stenoses on a hypoplastic vein on the other side. I have one case actually, I had an 18mm mercury gradient, which was unusual because most patients, the gradients I was getting was ranging from 1 to 5, very low level gradients. And in the venous system, it's very hard to achieve as opposed to the arterial system. If you have a gradient, you have a problem. In the venous system, it's very hard to achieve that. Your right heart pressure is about 0 to 5, your jugular pressure is like maybe 1 to 7, whatever. And any difference, if you have any flow through that area, you're not going to be able to detect that gradient. Plus the jugular venous system through the brain, it crosses over, it drains through the collaterals, so it's never complete the blood. There's always a backflow. And the idea that I think we all agree on is that backflow is the problem, even though the pressure that it creates may be too small to detect, it is the problem. So measuring the gradient is unfortunately not helpful as it is on the arterial system. That's my impression, but would you like to comment?
That was included as an endpoint in our study as just something that we were curious about because we started off measuring pressures and just found that it was
Not helpful.
not helpful.
How about the trial? Is that
Yeah,
part
it is
of the trial?
included, it is included in the trial.
So you're measuring. What do you think about itself?
I think if you have a sufficient number of collaterals, you will decompress the pressure, but the flow will be retarded and distorted. And the interesting thing about the back jets, if you talk to Franz Schelling about the back jets and causing the injury to the brain and around the deep cerebral veins, he's saying that that's caused by muscle contraction. In other words, you may have low pressure but very dilated vessels because of an obstruction at the valve, and that's really not doing anything, it's just getting diverted. But if you rotate your neck, or you open and close your jaw, or you flex or extend your neck, you compress that obstruction. And since that compression is going to generate force, and there's no outflow because of stenosis of the outflow, those jets go back into the head. And that's his theory that that's what's causing a lot of the demyelination, those lesions around the deep cerebral veins, around the corpus callosum, thalamus, all of those lesions that are so common. So I mean, we'd have to measure. I mean, if we really wanted to do it right, we'd have to measure pressures, inflection, extension, all those movements, to see what pressures are generated, because they're not really generated by just simple flow. So I don't know. I can't imagine using pressure. And besides that, we're trying to measure the difference between 4 and 2.
Yeah.
Are our measuring devices that sensitive? I don't think they are. I don't think they're accurate at that level.
I mean, it just, if you keep it long enough, it just changes anyway, it's not even constant.
I don't think pressure. If we had a flow meter, that might be really bad.
to it, Jerry?
What I think we're all talking about is the fact that the pathophysiology and the physiology in the venous system is so much more variable. It's affected because it is a low pressure system and a low flow system. We just were literally just at the beginning of our learning on this. I mean, we've actually come a very long way in a short time. But, you know, part of the reason why we start going off on tangents is because we just learn other things. When we were in Orlando, you know, one of the physiologists that was there was talking about the fact that it's probably more like a 10 or a 20% stenosis is significant in venous disease because it is a low flow state. You know, we're not talking about high pressure laminar flow with a pump behind it. And I believe he told me that that flow is related to artery of the fourth, right? And so 10 or 20% stenosis becomes much, much more significant. Whereas, you know, in an arterial system, a 50% stenosis is 75% diameter. A 50% diameter reduction is a 75% cross-sectional area reduction. So, you know, we're just learning about all of these things. I do believe, as Sal was saying, and I do believe possibly the CSF flow, you know, CCSVI may be an exacerbation, a disease process that exacerbates the symptoms of MS. I tell patients sometimes it's like, you know, if your tank is almost empty because of MS, and then you then superimpose another disease process that has similar symptoms, you notice those symptoms so much more because you're essentially have lost all of your reserve to compensate. And so you may have people that don't have MS that have CCSVI, but they don't notice the symptoms as acutely. And that's why we see probably the rapid improvement after angioplasty. You know, we've all seen patients that come in and they're non-functional in some way. I just had a patient a couple of weeks ago. For 6 months wasn't able to feed herself, and we did the CCSVI procedure for her, and she was feeding herself in her recovery room. So, again, I think we're just on the verge of learning all about this.
I completely agree. I mean, there are like different processes, but looking back at it, it could be that MS could be an initiator for CCSVI to happen, which is like a vicious cycle, kind of makes each one of them, kind of makes the symptoms of the patient worse. And hopefully you guys will help us soon. And any other questions from the audience? Please.
Yes, when it comes to the follow-up, how do you follow up on the patient?
I'll ask Sal, he's very passionate about it, and then I'm going to ask Dr. Englander how they do it in the trial.
First thing I would say is that unless you're very, very fortunate, you're not going to have much support from a neurologist. So in a sense, you have to learn to be an amateur neurologist. So at least I do a full neurological assessment of my patients before the treatment. I review their MRI, but I'm really more concerned with caring for patients, so I really think that looking at the clinical parameters is really important because it's not MS that we're treating it, in my view. So the first thing is you really got to get your own baseline because nobody's going to tell you anything unless you're very fortunate. I have my patients, there's two things that are going on. I think, number one, very quickly patients either have some improvement, most of the time have improvements or not. If they don't have improvements, you have to try to get a sense of why not. If they have improvement they lose, you have to find out right away why they lost the improvement. But otherwise, I tend to, if they're local, I like to see them at 1 month. And I really get a good sense from a 1 month follow-up.
Do you do any imaging at that time?
I always do it, when the anticoagulation is finished, within a few days, I want to know whether they have good flow and no thrombus. If there's any thrombus hanging around the valves or stuff, I'm going to put them back on anticoagulation for at least 2 more months. And I'm going to make sure that they don't, I'm trying to avoid them going on to thrombosis. Beyond that, the follow-up is generally I use ultrasound by the Zamboni protocol to look at the physiology of flow, but I'm not even sure it's too helpful. So you know, it's more of a clinical assessment of my patients. If they're doing well, I don't fix them. If they're not doing well, I try to figure out what's going on and fix them. But anticoagulation is, I'm paranoid, I'm obsessed with clot formation after angioplasty. When we started doing this, when many people in the United States started doing this in 2010, because we were missizing balloons and stuff, there were a lot of thromboses. You know, I would say in some practices 15% thrombosis. And if they didn't do follow-up, and the only time they found out follow-up was at 3 months, by 3 months you're not going to recanalize that vessel. And I feel very strongly that if they do thrombose, anticoagulation alone is not going to be effective in salvaging the vein. Anticoagulation does not, in general, recanalize the vein. That's what I thought was the right way to do it, but I gave that up quickly. Because if you wait 3 months to recanalize that vein, you've lost that vein forever, in many situations. So that's the key, is to look for that.
Dr. Englander, how about the trial? What's the protocol?
Patients receive baseline MRI and ultrasound that are followed up with ultrasound. And I don't remember the specific interval, but patients, all of our patients, regardless whether they're in the trial or not, receive an ultrasound 24 hours after the procedure. And then, you know, there's, I think it's 3 months, 6 months, 12 months ultrasound and MRI, I think it's 6 months and 2 years.
And they're clinically evaluated by neurologists, blinded?
Yes, blind neurologist does not know whether or not they received the procedure. And so they're evaluated as baseline and then genetic.
So, any other questions?
Yes, Dr. Sclafani, the narrowings that you see in the neck veins, what percentage are actually associated with valves?
85 or 90%.
And out of these that are associated with valves, can you always see them on angiogram, or sometimes do you not see them, and do you really need the ultrasound in them? And then the follow-up question is, Dr. Englander, are you really doing a disservice if you're not including ultrasound in your trial for evaluation for valves, if really 90% of the narrowings are caused by...
You mean intravascular ultrasound?
Yes.
Okay.
Let me take that first, because I think that if you start, you know, I think there's a learning curve, a very steep learning curve in recognizing very subtle abnormalities on the venogram. So in my original study, I looked at 30 consecutive patients who had azygous stenoses, and or they got angioplasty for azygous disease. And I can tell you that only 3 patients had clear-cut, obvious stenosis to me on a deep inspiration view, where the vein is expanded in inspiration. So many times it looks like there's stenosis, but if you take a deep inspiration, the vein just expands. We saw many abnormalities. We see a lot of reflux. We may see slow flow through the vein. But the site of the problem is very difficult to see, especially in the azygous vein, because there's misregistration because of the motion of the heart. In IVUS, almost all of the cases are directly diagnosed. So 25% of those 30 patients that were treated only had valvular stenosis seen on a venogram, on an IVUS. So I can't say that that's the same in the jugular veins, because the jugular veins' response to stenosis is to dilate. There's tremendous reflux and collaterals, and sometimes you see these bulging of underneath the valve in the sinus. Those are indirect signs of stenosis, so I'm not going to discount them. But it's not just for diagnosis that IVUS has merit. It also has it in selecting balloons, because the vein is not a circle.
Right, so going back to Dr. Englander, should you really consider including IVUS in your study, because this is so critical, as Dr. Sclafani is indicating?
We don't think so.
Just to clarify though, if you see slow flow, if you see collateral flow, just like Dr. Englander, if you see kind of reflux or reverse flow or contralateral flow, and on top of that, if you don't see any of this, but you see 50% stenosis on a vein that you don't see any of these, that is, I think, like more than 99% of the patients with MS.
Yeah,
right?
I mean, in our study, we've defined objective criteria which, there are going to be subtle findings. Maybe those patients, by the criteria of the study, are not going to be treated. If anything, that's going to make this study more sensitive. I think it's going to be more sensitive because we're not treating that many people.
Yeah,
if we start treating every lesion, I think it's harder to find what's
yeah, it depends on how you perform the venogram and how you interpret it. If your threshold on interpretation is different, just like Dr. Sclafani said, or how you perform it is not the right way, you're going to miss a lot of lesions if you abide by certain criteria that you hold. But if your venogram technique is consistent and looking at not only just in one image what the narrowing is looking like, but looking at the rate of the flow, looking at reflux, looking at if you can do fast frame imaging, you can actually see that focal area catch as the contrast is going through the narrow segment. You can get that image if your frame rate is fast, meaning that you're acquiring more images during the time contrast is flowing. But if you're acquiring images intermittently, there's a very good chance that you won't see what's happening at the base of the neck. Yeah. So there's a lot to do it rather than just, basically saying 50% or, or less or more.
One of the things that we really need to do is standardize the diagnostic portion of this examination. And I would agree you need to place the catheter in the sinus when you're injecting so that you can image the entire jugular vein. But then there are questions, do you do the filming with the patient holding their breath? And is that in end expiration or end inspiration? Do they do a Valsalva at the time? Do they just do quiet, shallow breathing? In a low flow state, like the jugular vein, all of those things are going to affect it. And then, so if in my center I do it one way, and somebody else's center they do it another way, and they measure the degree of stenosis a different way than I measure the degree of stenosis, we just have so much variability that we have to really try to get a standardized approach.
I'm not saying that we should do this treatment under IVUS and forget the venogram. They're really, personally think the gold standard is venography plus IVUS. That's going to capture the most valvular stenoses. It's going to detect webs and membranes that you can't really see on venography most of the time. On the other hand, you really don't get a good sense of the flow because the catheter is not a measure of flow. It's just a B-mode ultrasound, so it's not giving you some information on flow. I think if we had a flow meter, that would be really useful, but we don't have that yet. But Jerry, I agree with you, but I'm not so sure we have any rational way to argue whether I'm right or you're right. We don't have that yet.
I agree.
So I think it's wonderful to have a trial of a single center, but the ultimate is going to be to have multi-center study and then compare the different outcomes based on the variables of treatment. That's the only way, and diagnosis. And that's the only way we're going to come to best